Hello everyone, it's me Dr. Ayaz Ahmed. I am working as a aesthetic dermatologist. Today I will discuss another important topic of dermatology. The name of topic is classification of psoriasis. Hopefully you will learn and subscribe my YouTube channel. Psoriasis can be classified on the basis of sites, on the basis of age, on the basis of precipient factors, on the basis of morphology. So today I will only discuss the classification of psoriasis on the basis of site involved. Number first is the scalp psoriasis. It is the most common first affected area of plaque psoriasis. Scalp may be diffusely involved or there may be discrete plaque. Very thick plaque may also develop at the occipital area. Plaque may be limited to or slightly extend to hairline. It does not affect hair growth. Plaque may be adherent to scalp or hairs. This condition is termed as the psoriasis amenorrhoea. It is common in children and young adults. This is the first clinical pictures of scalp psoriasis. It is commonly termed as the psoriasis amenorrhoea. Scalp hair in case of psoriasis amenorrhoea shows just like a tinea capitis. The plaque hair in case is adherent to scalp and hairs. Number second is the follicular and seborrheic. As the name indicates, follicular psoriasis affects follicle on the trunks and limbs. It may be as an isolated phenomena or it may occur with plaque psoriasis. Lesions are similar than gutted psoriasis. They may be in group or they may be found in diffuse states. It resembles with PRP in children. Moreover, seborrheic affects seborrheic area, for example, paranasal area, external ear, medial eyebrow, hairline, pre-sternal area, and intracapsular chest wall. It may present with coeval phenomena. This picture describes the involvement of psoriasis in follicle. Now, flexural psoriasis or inverse psoriasis. This type of a psoriasis usually involves the folds of a body. For example, inguinal folds, axillary fold, submammary fold, gluteal cleft, and umbilicus. It is a common in old patients and associated with obesity and plaque psoriasis. It may occur primarily or as a coeval phenomena on the top of infective or seborrheic intratriginous dermatosis. Failure to respond to antibiotic and antifungal arose suspicious of inverse psoriasis. The plaques are thin and scaling is reduced or absent. Surface has glazed hue and fissuring at the depth of skin fold. This picture describes an example of flexural psoriasis. Here fold is involved. The submammary fold, you can see the big plaque is present in the fold area in between the chest and left mammary glands. This is another example of flexural psoriasis. Here umbilicus area is involved. You can see plaque is present around the umbilicus with scaling and salmon rich red color. Genital psoriasis. It affects genital skin. Genital skin has similarity with flexural skin. It usually involves skin of the scrotum, shaft, and glans penis. The glans penis is the most common site affected in genital psoriasis. The biopsy is necessary as it may resemble with erythroplasia or plasma cell balanitis. In female, erythematous symmetrical scally well demarcated plaque affecting labia major is commonly noticed. It is the common cause of chronic uveitis in children. This picture describes the involvement of psoriasis in genital area. You can see the plaque in the margin of glans and on the upper surface of the shaft with whitish color. Non-pustular palmoplantar psoriasis present with scaly patch with fine scale which can be evoked by scratching. The plaque is not well defined, resemble with lichen simplex or hyperkeratosis eczema or pustulosis. Sharply defined edges at wrist, arm and forearm or palm and absent of vesiculations. Dorsal surface, knuckle showed red thickening of the skin. This picture describes the involvement of palmoplantar psoriasis. You can see the plantar surface of both feet are involved here. There is a thick hyperkeratotic skin with scaling and fissuring. In this case, the both hands are involved in palm area with thick plaque involving both heads. Nail psoriasis. Nail growth is faster in psoriasis. Nail dystrophy is commonly seen in all type of the psoriasis. Nail pitting and nail unit abnormality is commonly seen. Nail psoriasis is associated twice increase with psoriatic arthritis and longer duration, strong family history and extensive disease. Nail abnormality includes nail matrix disease and nail bed disease. The nail matrix disease features are pits formation, ridge formation and groove. Moreover, the nail bed disease are subungual oil drop. It is the most specific in psoriasis. Other features of nail bed disease are hyperkeratosis, splinter hemorrhage and onycholysis. This picture describes the oil drop sign in first picture. You can see there are oil drop sign on the right side of the nail. Moreover, on the left side small pits are also seen. These both signs are noticed in psoriasis. This picture describes the hyperkeratosis, subungual hyperkeratosis and proximal onychomycolysis of the nail. It is most commonly seen in psoriasis. Always note that involvement of nail in case of psoriasis indicate extensive psoriasis, strong family history and twice chance of psoriatic arthritis in these patients have been noticed. Mucosal and ocular lesion in psoriasis. Psoriasis also affects oral mucosa. Fissuring of a tongue and geographic pattern of a tongue are commonly noticed in psoriasis as compared to healthy control. Ocular change in psoriasis are strongly associated with psoriatic arthritis. Changes include blepharitis, conjunctivitis, xerosis, keratitis, and uveitis. This picture describes the geographic tongue of the psoriatic patient, although it is not commonly seen in other patients. Thank you very much. Stay connected and subscribe my YouTube channel.